Welcome to the Innovations in Cardiology podcast. I'm Dr Itchhaporia, and we have the distinct honor of speaking to one of the most influential figures in cardiovascular medicine, Dr. Valentin Fuster. Dr. Fuster is the director of the Mount Sinai Heart and physician-in-chief of the Mount Sinai Hospital. He's renowned for his groundbreaking work in cardiovascular research and in his contributions which have shaped the way we approach heart health today. Dr. Fuster, it's a pleasure to have you with us today.
Thank you, Dipti. It's a pleasure to be here.
So there are so many topics that I can talk to you about, Dr. Fuster, but I know one that recently you have spoken a lot about is about this difference between the chronological versus biological aging. So I thought we would start with that. You've really been a pioneer in exploring the differences between chronological and biological aging. Could you explain how this distinction is revolutionizing our approach to cardiovascular care?
Well, the question is important because we see people age 70 that look like age 90, and we see people age 70 that look like age 50. And it's becoming more and more important to us to really look at the biological age when we make decisions than the chronological age. And the factors that appear to be influential are a number of them. For example, one of them is the bone marrow, which is a very new concept. The bone marrow has a defense mechanism against inflammation, for example, even against atherosclerotic disease. And some of us have very active bone marrow. Some of us have a less active bone marrow. The second issue that is very important is methylation. And that is, methylation is a concept that evolved during pregnancy on women who smoke. And then this affected the children. We now know that methylation, actually, biologically speaking, is not a good news and actually can be measured. And many people now are measuring biological age by the degree of methylation that we have in our molecular basis. The other aspects that are very important now is the aspect of the bone marrow in terms of mutations. And that is, this is becoming very critical. And that is, there are people who have significant mutations of the bone marrow, and the defense mechanism actually fails, and life gets shortened. So what I'm really telling you, that there are the telomeres is the fourth one that is important, and that is, as the cells divide, there is a little bit of genes that are being lost, and the question is how they be replaced. And this is a telomere that is present in the chromosomes. What happens is some people shorten the telomere to a way that at the very end, the cells cannot multiply. And this appears to be affecting biological age. So bone marrow, mutations in the bone marrow, the degree of methylation, and then the final one that we just mentioned that is important is the telomeres. These are the four aspects that appear to be critical in biological age versus chronological age.
Okay, but if I want to know what my biologic age is, how am I going to do that today?
Today, I think that is more of a phenotype that you present in the measure of the methylation. These are the two things that I would say. You know the phenotype, your risk factor profile, how you look at, and so forth. And if you want, from the chemical point of view, to look at something that gets closer, methylation probably today is the most important factor.
So can I use this information? What can I do right now knowing that there is truly a difference between chronologic and biologic aging? Should I start earlier? Should we start looking at, you talk a lot about the fact that we're not looking at children and that we should be looking at these people very early on. And that you even mentioned that, we should be screening these people starting at the age of 20. Am I correct?
You are correct, but I will tell you the following. The four aspects that I mentioned to you that play a role in biological age, the same risk factors that we talk about life, particularly in the cardiovascular system, affects the four of them. So what I'm really saying to you that if you have to do something today, just take care of yourself. 8 risk factors, and 2 risk factors are actually physical: obesity and blood pressure. 2 chemicals, cholesterol and glucose. 3 behavioral: cigarette smoking, lack of exercise, or poor diet. And then people like to add sleeping. If you take care of all of these, you are really going in favor of prolonging biological age.
Okay, and I agree with you, but let's talk about cholesterol. Let's just pick one. But there's treating cholesterol. If you look at the guidelines, I'm not sure they're being as aggressive as you're telling us to do to be able to really mitigate those risk factors. So what should I be aiming my LDL cholesterol to be?
Well, people don't like to hear me on this, but to me, the guidelines are very primitive. Why? Because a key measurement of atherosclerotic disease is the silent atherosclerotic disease, which can be done by 3D ultrasound of the external arteries. I am saying this because we get into Framingham or the European scoring just looking very late, and not really, these guidelines have nothing to do with subclinical atherosclerotic disease. What I can tell you that we and other groups have seen that if you want to have a normal cholesterol, you should look at the subclinical disease, and you end up that the normal cholesterol is less than 60. So LDL cholesterol, I'm sorry to say. So what I'm saying to you is that we have to be very aware that all the risk factor profiling that affects biological age actually doesn't take into account one aspect, and this is silent disease. And maybe we have to start screening people at age 20 rather than at age 40 or age 50. And one of the screenings will be imaging, for example. The question is cost, but this is a different discussion.
Well, but we're talking about innovation. So do you think there's some new things coming out innovatively with AI or other digital tools that may make this a little bit easier for us to do?
I agree.
Have you used any of those techniques yet in your research?
Well, we are really very much into the imaging now, and you should know that we already imaged 12,000 people, apparently normal at different ages, and you will see some of the articles coming out on this. And actually, we are now convinced that we have to start the atherosclerotic process begins at age 20, age 25. So we have to really go much earlier. Then I think we will affect biological aging, as you began to ask for.
Have you thought about applying AI to any of these imaging modalities, the studies that you've done?
Well, about AI, I will tell you, we did a study on AI, which is the risk factor profile in 6,000 people between age 40 and age 55. And we found not 8 factors, as I mentioned to you, we found 40. But the only thing I'm saying to you is how much we don't know that has to be explored. But I think the bottom line is our health has to be taken care of much earlier in life. Then I think we will prolong the biological life, and then all the parameters I mentioned to you, the 4 parameters, will be much better if we do that.
Now, one of the other things that you like to talk about that I've heard you recently talk about is the brain-heart connection. It's another fascinating area. It's sort of looking at that intricate connection between the brain and the heart. So how is this relationship influencing our understanding of cardiovascular diseases? And what are the innovative approaches being developed as a result?
Well, I think the most important issue to be addressed is that the risk factors that affect the large arteries, including the coronary arteries, are affecting the microvascular of the brain. We have a lot of data, and many investigators have this information. This is a very hot topic today. Why? Because we begin by having problems with what we call cardiovascular system, stroke, heart attacks, peripheral arterial disease, but we don't pay attention what happens to the brain slowly.
Right.
And this has a lot to do with the microvascular of the brain by the same risk factors that we talk about large vessel disease. There's something interesting here. And this we learn this from the pathologists. Hypertension, hypercholesterolemia, diabetes do not cause the atherosclerotic disease in the tiny arteries of the brain. What they cause is intimal hyperplasia. And therefore there is a decrease in flow, and this slowly affects cognitive function and eventually senile disease, and we believe also acceleration of Alzheimer's, which is a complex entity, but the progression of the disease, I think, has a lot to do with risk factors. So going back to your question, I will tell you it's better we pay attention as cardiologists by saying it's not only the heart, but slowly later is the brain what is being affected by us not taking care of the factors that affect the heart first.
Right. And I agree. But as you know from taking care of patients, there are patients that feel like if they take, say, statin therapy, that it causes more cognitive dysfunction. But what you're saying is just the opposite.
Well, what I'm saying is the following. We see patients. I saw a patient today. Says, doctor, you're a torture. You're asking me to correct all my risk factors at age 60, and I want to enjoy life, and I prefer to die suddenly. And this was my answer. What about your brain? Do you realize that by not taking care of yourself, the brain can be affected later, and it's a slow process, it's not suddenly. And I will tell you my experience with this talking to patients is very impressive. What I don't know are the results. But they react and they listen to you when you talk about the brain rather than the heart. So it seems to me that people are becoming much more sensitized to the issues of the brain than the issues of the heart today. So let's take advantage as cardiologists.
Right. I think it's just scary when you think your brain's going to stop working, whereas maybe they don't really appreciate that with the heart. So very good point. I want to talk then about the fact that when we're talking about patients, people don't want to take a lot of pills when you identify their risk factors. So this whole concept of polypill has been around for a while. And you know this very well because you championed the whole concept of polypill and the potential to how it can transform cardiovascular prevention, particularly in the resource-limited settings. So can you just share your insights on the current status of the polypill and maybe the future potential? And maybe make us understand, why has it not taken off the way it looks like it should?
I will be brief. I will tell you that the beginning of the polypill is that one of the main issues in the cardiovascular disease entity is people don't take the pills. The adherence is very low. In our freedom study, diabetic patients with coronary multivessel disease, only 20% did the right things, addressing the risk factors, taking the right medications. This created, to me, a tremendous degree of depression by saying we are discussing surgery versus PCI, when in fact, people are not taking the pills. The problem with the pills is people started with primary prevention, thinking that a polypill for primary prevention would be the answer. I was completely the opposite side. I sought for secondary prevention, but people were not talking with secondary prevention. So I started 15 years ago, and the start was very rough because the main companies in the United States were not interested because of the experience with HIV. It became very expensive to make a polypill for HIV. So when I said to them, can you help me? They said, this is very interesting concept, what you want, but we are not interested. So I started in Spain with a small company, and the first polypill cost 20 million euros. You know why? Because we had to do 40 polypills to have the pharmacokinetics of each of the pills to be right. And this is what people don't realize, that when the pills are together, they interact with each other. And this is very expensive. Anyway, we won that. We learned. We did the first polypill, which was aspirin, simvastatin, and ramipril. And we found in a 6-country study, the focus study, that adherence was much better with the polypill following myocardial infarction than taking the pill separately. Once we learned that, to go fast, we developed the secure study, which is a prospective study in saying you may have better adherence, but you decrease cardiovascular events. And the SECURE study was a study of 7 countries, 2,500 patients with MI. Half of the patients were on a polypill. In this case, was actually atorvastatin 40, aspirin 100, and then ramipril 2.5510 in a period of 3 weeks to be sure there is not anaphylaxis. And this was compared with placebo. The bottom line, mortality decreased by 31%, cardiovascular mortality, which is highest that even was achieved for secondary prevention with the aspirin. This led very quickly to the WHO to actually nominate the polypill as a needed, which is very difficult. And this actually came back about 6-9 months ago. So when you say, how is possible that the polypill didn't take off? It's because it was very much focused on primary prevention. But on secondary prevention, now what we have to do has been approved in 30 countries in Europe and South America. We are now dealing with the FDA, and I think soon we will have a polypill for the whole world, which will be patients with myocardial infarction, aspirin, ramipril, and atorvastatin. And I don't want to talk now about patients at high risk or peripheral vascular disease. I will only tell you if you ask.
Right. Well, I want to clarify, because the polypill really is the combination that you mentioned. But there are people that do combinations for hypertension, and they call that a polypill.
Very important.
That's not really a polypill.
This is different.
Right.
Polypill means different pills that have different actions.
Right.
If you treat blood pressure with pills that only drop blood pressure, you call this polypill, but this is not my definition of polypill. My definition is what happened with HIV and what happened with secondary prevention. This is what we talk about, pills that have different actions and address one entity. That's the polypill we are talking about.
Right. Well, let's look into the future, Dr. Fuster. So if you look ahead, what do you believe is the most impactful innovation in cardiology over the next decade? What do you think is going to be the most impactful?
Well, you're going to laugh.
Okay, make me laugh.
That's okay. You're a good friend anyway. Look, Dipti, I think it's primordial prevention. Very young people. To me, we can talk about new drugs. We can talk about artificial intelligence. You can talk about new procedures, structural heart disease. But if we don't prevent the disease, we are going backwards. And to me, to prevent the disease, we already have a lot of information that there is nothing better than to go to childhood. And at the same time, to look at young people for risk factor profiles, age 20. But the educational aspect is much earlier. And I think if you're asking me this question, what is going to be the main thing, you probably are going to laugh. But I will tell you, I feel very strong, Dipti. We have to go much earlier and to prevent the disease. And we are not doing so. We are so primitive.
Right. Well, there's a ton of money being spent on digital health tools, artificial intelligence, all of these things to augment our intelligence in terms of taking care of patients. Do you think that any of these emerging innovations are going to help us with what we need to do in the next decade?
It will help us, the algorithm, the artificial intelligence, having algorithms that will very quickly tell you what to do with patients. That is diagnostically speaking and therapeutically speaking. And I think the only problem I see with artificial intelligence is that the young people who are going to be cardiologists, I don't know what the education is going to be, because today they already don't talk to the patient. They all go to the computer. And what I'm saying to you, I think this is going to be a huge problem on the aspect of the patient, which is the patient's soul. And I think this is critically important. I am all for artificial intelligence. It's going to help us with all the algorithms. But please, let be doctors. Let really be doctors who are able to talk to our patients. And then this is the aspect of artificial intelligence that I'm a little bit worried about it, but it's going to be a big advance in medicine. Now, however, when we go to education of people, I'm not entirely sure what artificial intelligence is going to do to go to children and telling them how to have a better health and better life. I'm not sure artificial intelligence will get there. So summarizing my views is I'm all for artificial intelligence. This is like electricity. It's going to be a big change, and it's going to be in front of us. But be careful. We all have a soul. We all have to be educated, and we all have, an intelligence to be used properly. And I'm not entirely sure how artificial intelligence is going to help this aspect. This is what I tried to tell you.
Right. Now, I wanted, in closing, because we're coming to a close here, is if you were back and starting your cardiology fellowship and looking at a future in cardiology, what is it that you would focus on?
Well, to a fellows, I would tell 4 things, Dipti. The first thing to tell, give thanks to the world, because they are 1 in 1,000 who reach a stage in life that, speaking from the social economic point of view, they are really on the top of the hill. So stop criticizing and be creative. That's the number one thing that I would tell to people. Second, something that young people don't like is mentorship, tutorship. How at age 20, 25, you think you already reach a stage that you can decide for everything, when me, for example, at age 81, have 2 mentors. Actually, life gets complicated as it evolves. So the concept that you are age 20, 25, and you don't need people to help you who you are is a huge mistake. Importantly, the tutor will tell you what is your talent, and this is the best investment that you will have in your life, is to use well your talent. Number 3, and that is team effort. I evolved in a very singular way, research-wise and so forth, 50 years ago. Today, you're part of a team and you're under a microscope. So those of you young people who don't think that a team is important, you will crash. That's my third thing. And the final thing, actually, is resilience. And that is to think that life is all going up when in fact that's this, ups and downs. And the question is, how do you solve when you are down? And how do you move up? So these are, to me, the 4 advice counsels, or at least concepts, that are important to tell a young person as he starts a career as a cardiologist.
Well, we'll end with that, but that's a great piece of advice. Thank you, Dr. Fuster. Your insights are always incredibly valuable. And I hope that we get a chance to come back and talk a little bit more about the brain and heart and chronologic versus biologic age, and see where you are in the near future with all of this work. So thank you so much.
Thank you very much. Thank you.